Hello everyone, hope all of you are safe and doing good in this COVID era. So in this COVID era, as we all are simply sitting home, we have ample time to learn new things and new topics. So me and my friends, we came up with a very short and informative video for you all, and we hope that you will like it. And so first of all, let me introduce myself. Hello everyone, it's me Yashika. Me and my friends Shrishti, Prerna and Simran, we all are pursuing post-graduation in audiology and speech-language pathology from Aliyawarjang National Institute of Speech and Hearing Disabilities, Divyangjan, Calcutta. First of all, I would like to share a few things about my institute, like its objectives, its history, and what are the services which are being provided there. So let's start. Aliyawarjang National Institute of Speech and Hearing Disabilities, Divyangjan, Regional Center Calcutta was established in 1984 as the first regional center of AYJ NISHD. It is an apex autonomous national institute under the administrative control of Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment, Government of India. Our institute is equipped with modern equipments for carrying out various diagnostic tests for hearing, speech and language related disorders, as well as behavioral and vocational aptitude and educational assessment of persons with hearing and speech and language related disorders. All of the services provided in the institute are subsidized. The institute also provides adequate facilities for vocational referrals, and the institute also aims to empower persons with hearing disabilities to involve themselves in meaningful work opportunities. The institute is involved in holistic approach towards rehabilitation. So now we will discuss the objectives of the institute. The objectives of the institute are manpower development, research, educational programs, service facilities, community program, material development, information and documentation. So this was a very basic and brief idea about my institute and everything I wanted to share with you regarding the services which are being provided here. So let's move to the next part of the video, and I will provide you few basic information about stuttering. Do you also laugh when you see someone who's stuttering? Please don't laugh. It is not a matter of laughing. Rather, try to understand the challenges faced by a stutterer. Stuttering is a speech disorder that involves frequent and significant problems with normal fluency and flow of speech. People who stutter know what they want to say, but they have difficulty in saying it. For example, they may repeat or prolong a word, a syllable, or a consonant or a vowel sound, or they may just pause during speech production because they know they might stutter on that particular word and they hesitate in saying it. So, stuttering is not a matter of laughing. Please don't laugh at stutterers. It has specific core behaviors also. So let's see what are the core behaviors of stuttering. Repetitions, prolongations and blocks are the three main core behaviors of stuttering. Repetitions are most frequently observed among children who are beginning stutterers. They can be single syllable repetitions or word repetitions. And prolongations, they may be voiced or voiceless sounds, thus stutters, in which sound or airflow continues but the movement of articulatory structure is stopped, is referred to as prolongation. Prolongation usually appears later than repetitions. Blocks, they are typically the last core behavior to appear, and they occur when a person inappropriately stops the flow of air or voice and often the movement of his articulators as well. Individuals who stutter are aware about their stuttering and are often embarrassed by it, but children who are just beginning to stutter may not always be highly conscious of it. Now just see the secondary behaviors associated with stuttering. The secondary behaviors, yes, they are the associated behavior and they occur because the stutterers, they react to their repetitions, prolongations and block by trying to finish them quickly, as if they can't avoid them altogether. Secondary behaviors are divided into two major parts: escape behaviors, avoidance behaviors. Escape behaviors occur when the speaker is stuttering and attempts to get out of the stutter and finish the word. The escape behaviors, the examples might be eye blinking, facial grimaces, head nodding, or use of interjections or extra sounds such as and avoidance behaviors. They occur when a speaker anticipates stuttering, such as the stutterer may change the word or pause. All of this is to prevent stuttering from occurring in real situations. So, as we all are aware that the stutterers, they also have some negative feelings due to the stuttering. They might feel shame, frustrated, embarrassed, and depressed sometimes. So, my friend Shishti will tell you about the next topic.
Thank you so much, Yashika. Now we all have a general knowledge about stuttering and its core behaviors. Prior to the discussion, I want to introduce myself. So, hello everyone, I am Srishti Chan, student of AYJ and ISHT. Right now, I am pursuing my post graduation in audiology and speech language pathology. So, today I am going to discuss the life of person with a stammer. As we all know that stuttering is a disorder of speech fluency that commonly appears between the age of 2 and 5. A child with stuttering not only experiences academic and social consequences but may also faces the emotional and behavioral disorders. So I am here to discuss about the negative behaviors and attitude, factors that leads to stuttering, the consequences of stuttering, severity of stuttering and vice versa. So let's proceed with our discussion. Negative behavior and attitude associated in person with a stuttering. These include shame, fear, guilt, lower self-esteem, negative attitude towards speaking, and negative attitudes towards others. So these are the common behaviors that are majorly seen in persons with stuttering. Factors contributing to the onset of stuttering are less influential factors and more influential factors. So firstly, less influential factors. These factors do not have a strong influence on precipitating the problem of stuttering. First, physical development. Same general physical makeup as children who speak normally. No evidence that children who stutter are distinctive in terms of general developmental milestones. Second, illness. Silverman 1906 point out, if illness affects central nervous system, a cause and effect relationship between illness and onset of stuttering may be possible. Children with stuttering do not appear to have more illness than those who do not. Third, imitation. This consideration of stuttering onset may be influenced by the culture of the speaker. Example, Utsuki 1958 reported that in Japan, imitation was viewed as a major causal factor in 70% of his cases. Fourth, shock or fright. Parents may report the onset of stuttering following a traumatic emotional event when Riper 1982. Parents may report the onset of stuttering associated with an event without knowing that their child had been stuttering for some time in schools and other locations. Fifth, emotional and communicative conflicts. Some parents suspect that a variety of interpersonal and family stresses can bring about stuttering. There is no indication that children who stutter have a greater number of emotional conflicts than their normally speaking counterparts. 6. Socioeconomic status. Few data available indicates that stuttering is present in all socioeconomic groups. When Riper 1982 reviewed several studies that report varying amount of stuttering across both cultures and races. More influential factors. These factors have greater influence on likelihood of stuttering. First is gender. Kent 1983 discussed the fact that higher occurrence of stuttering in males is one of the few consistencies about the disorders. Females are more likely to recover from stuttering during preschool years than males. Second, age. Children who are approximately 2 to 7 years of age are more likely to begin stuttering than older children, adolescents or adults. Andrews 1984 suggests that the risk of developing stuttering drops by 50% after age 4, 75% after age 6 and is virtually nil by age 12. Third, genetic factors. Bloodstein 1995 review indicates that percentage of persons who have relatives on paternal and maternal sides who stuttered ranges from 30 to 69%. Research during past few decades has indicated a genetic component in selected groups of people who stutter, according to Cox et al. 1984. Twinning. The relationship of twinning is to stuttering, of course, closely related to the genetic factors. Approximately one-third of all twin pairs are monozygotic pairs and are genetically identical. This is especially true if twins are monozygotic. It is less likely that both members of fraternal twin pair will stutter. Brain injury. When Riper 1982 summarizes findings that report considerably greater than 1% occurrence of stuttering with brain injury, especially for speakers with cerebral palsy and epilepsy. However, it can sometimes be difficult to distinguish motor speech and language problems part-word findings from fluency breaks. Speech and language development. As a series of studies of Andrews and Harris 1964 concluded that children who stutter typically achieve lower scores than their peers on measures of receptive vocabulary, age of speech and language onset, mean length of utterance, and expressive and receptive syntax. Recent investigations suggest that relationship of stuttering and expressive language and phonological abilities is far from simple. Motor coordination. There is some evidence that adults who stutter have greater difficulty in fine motor coordination. A significant part of act of speaking is a motor skill, and any delay or deficit in this aspect could certainly or adversely affect development of normal fluency. So this is all about the factors that are contributing in stuttering. Classification of stuttering. Stuttering is classified as into three types: developmental stuttering, neurogenic stuttering, and psychogenic stuttering. Developmental stuttering is the most common form. It is initially noted in children between 3 and 8 years of age and accounts for more than 80% of stuttering cases in the general population. Approximately 75% of preschoolers with developmental stuttering spontaneously recover within 4 years. Second, neurogenic stuttering. Neurogenic stuttering usually follows a neurologic event such as traumatic brain injury, stroke, or other brain damage. It usually occurs due to the damage of central nervous system. Third, psychogenic stuttering. Psychogenic stuttering is rare and involves rapid repetition of initial sounds. It usually occurs in adults with a history of psychiatric problems following a psychological event or emotional trauma. There may be no other known etiology. Severity of stuttering. The initial assessment should establish the severity of speech disfluency. The Stuttering Foundation of America recognizes 3 levels of disfluency: normal disfluency, mild stuttering, and severe stuttering. Normal disfluency, which occurs between 18 months and 3 years of age, is characterized by repetitions in sounds, syllables, and words that usually occurs at the beginning of a sentence. Children with normal disfluency have little or no frustration or awareness of their stuttering. Second severity is mild stuttering, that usually occurs between 3 and 5 years of age. Children with mild stuttering often present with similar repetition in speech as those with normal disfluency. However, the repetitions are more frequent and may be accompanied by secondary behaviors. Although patients and their families may not be concerned by mild stuttering, early detection and referral to a speech-language pathologist is highly recommended to decrease the frequency of stuttering. Third severity is severe stuttering, that usually occurs between 1 and 7 years of age. Although the levels of severity within the first 6 months of onset does not reflect the likelihood of spontaneous recovery, a pattern of recovery should demonstrate reduction in symptoms after 6 months. In most patients with severe cases, stuttering occurs with less than 20% of words. However, stuttering occurs with almost every phrase or sentence, is usually accompanied by secondary and avoidance behaviors, and often lead to embarrassment and fear of speaking. So this is all about the severity of stuttering. The Consequences of stammering. Recent surveys showed that stammering can have a significant impact on a person's career, social life, and mental and emotional well-being. The first consequence is bullying. Numerous studies shows that children who stammer may be at a higher risk of bullying than children who do not stammer, starting from the preschool years through to adolescence. In summary, a substantial number of children and teenagers who stammer are likely to experience negative reactions from others because of their stammering, which in turn will affect their attitude towards themselves and their stammer. Second consequence is mental health. Unsurprisingly, people who stammer can develop strong negative thoughts and feelings about their stammering, and many studies have supported this. In 1998, Corcoran and Stewart carried out in-depth interviews with adults who stammer and identified suffering as a principal theme, with people reported feelings of helplessness, shame, and fear, and resorting to avoidance as a way to hide their stammering. Third one is employment. Stammering is a significant vocational handicap, according to Hurst and Cooper 1983, and many employers hold negative attitude towards people who stammer. Research by Butler in 2014 indicates that people who stammer face daily causal discrimination at work, then the normal recruitment process with interviews work against them, and they often do not achieve their potential but instead settle for menial jobs with little communication demands. The impact on quality of life. Quality of life can be described as the general well-being of a person or society, defined in terms of health and happiness. People who stammer frequently report a reduced quality of life and that the ability to fulfill their life ambitions has been limited. Positives. It isn't all doom and gloom. Research has shown that people who stammer bring particular strengths such as empathy and compassion for others, personal growth and strength of character, resilience and creativity. Butler 2014 also identifies strengths such as listening, intelligence. This ties in with Brocklehurst's 2014 study, where he reports respondents identified a variety of strengths associated with their stammering and the number of ways in which stammering had a positive impact on others. So it is clear that the research stammering can have a significant and long-term impact on people's life. So what are the challenges faced by the stutterers? Situations that fluent speakers take for granted can be really tricky for those who stammer, and these includes introducing yourself, example at school, at work or socially, ordering a coffee, giving your name at a reception desk, navigating a voice-activated helpline menu, talking on the phone, using a smart speaker, and using an intercom. So these are the challenges that are usually faced by the persons who stutters. In summary, we find that persons with stuttering are often stigmatized by society. They are unfairly stereotyped into a group which is often believed to be less intelligent or capable than the average individual. Blood 2003. As a result, persons with stutterers often have impaired self-image as well as negative attitude and feelings in regard to their ability to communicate. Many persons with stuttering avoid social interaction as much as possible, which may reduce their chances to find partners and friends. It is very reasonable for persons with stutterers to avoid both intimate and platonic relationships, since research shows that majority of people do not find those who stutter to be acceptable partners or friends, according to Shears 1969. So this is all about my topic. And now my friend Prerna will discuss about the assessment of stuttering, as there is much need to identify those symptoms that are associated with the stuttering.
And hello everybody, I am Prerna. Hope you have learned a lot many things in our previous slides on stuttering that will make you aware about the disorder. Now, I am going to give you a brief idea about how being at home you can observe the behaviors of stuttering and also how a SLP diagnoses the disorder. If you keenly notice, being at home you can observe many signs and symptoms, which are facial grimaces and body movements like jaw jerking, tongue protruding, lip pressing, eye blink, jaw muscle tense, head movement, finger tapping or foot tapping, leg movement, poor eye contact. It should be noted that the symptoms varies from child to child and from person to person. Hope you have got the few idea about the signs and symptoms. Now it is very important to know when to visit an SLP or speech language pathologist. Like most kids who begin stuttering before the age of 5 stops without any need for help. But if your child stutters after the age of 3 to 5 years of age, or the situations gets worsens like repetitions, blocks, hesitations, along with the body movements and the facial grimaces, at this moment of the time, seeing an SLP is a very good idea. Now I would like to introduce that how SLP diagnoses the disorder. It is divided into 4 parts. First, the general foundation. Second, the case history. Third, the formal and the informal testing. And the last, the provisional diagnosis, in which we give the final diagnosis of the problem. Now the first general foundation, which includes the hearing evaluation, speech and language evaluation, and also the voice evaluation for the investigation, as these may affect the child's or person's fluency, which leads to stuttering. Now the case history part. This is a very important part to obtain the background information to determine the parents' reaction towards the child's, whether the child is aware or unaware about the problem, and also its performance at the school. Basically, we are finding out the impact on emotions, social skills, and how it is affecting at his workplace before going ahead to our core testing. Now, our core testing includes the formal and the informal testing, comprises of the standardized tools and non-standardized tools in the form of questionnaire. I would like to show you a few diagnostic instruments which are used in our testing. These are first the SSI, this is a stuttering severity index 3 and 4, which is from age 2 years. The TOCS, test of childhood stuttering for the age group 4 to 12 years. The third test, the documenting stuttering in real time. This is for the all of the age groups. The fourth test, the speech questionnaire, which assesses the psychosocial stress in stuttering. This is for the age group 8 to 17 years. Now the next test, the repeated scale based assessment by the therapist. This is also for the all of the age groups. And the last test is OASES. This is the overall assessment of the speaker's experience of stuttering, which is divided into 3 sections, one for the child, one for the teenager, and the last one for the adults. So this is all about the diagnostic instruments. Hope you find this informative. And please kindly note that the stuttering can be effectively managed. Practicing and embracing your speech may help reduce your stutter over time. And please develop a supportive network of family and friends. And most importantly, please stay tuned with your very own speech and language pathologist. And at the last, I would like to say, please keep watching this video, as my friend Simran will help you to learn more about the stuttering. Till then, goodbye.
Hello everyone, I am Simran. I am pursuing post graduation in audiology and speech language pathology from the Ali Awarjung Institute of Speech and Hearing, Kolkata. As my friends Yashika, Srishti and Prerna told about the stuttering, its type of severity and it's about diagnosis. First of all, thank you guys to describe wonderfully about stuttering. Now I would like to tell about management of stuttering and which therapy technique are used in reduction the severity of stuttering. So there are so many therapy techniques for both children like preschool children, elementary school children, mid and high school children and adults. So let's introduce therapy technique first for the children. There are so many therapy techniques like loose contact, bounce technique, hard easy speech, but mainly analogies and the fluency initiating gestures are used. As for adult, there are so many therapies, but mid was delayed auditory feedback, prolongation, and deep shallow breathing are used for both adult and children. First thing is most important which keep in mind is learn about respiratory pattern because it play major role in speech. Therapy should tell about proper inhalation and exhalation and deep shallow breathing and also tell about how we speak on exhalation and then practicing taking in deep breath and then slowly exhaling while saying a single words, then gradually increase to speaking to longer phrase and sentences while using gentle exhalation. Should talk about breathing time during conversation, especially about when to take breath. If our breathing pattern is wrong, then it increases severity of problem very rapidly. So now I will tell about the analogies that are used in children. So first one is the garden hose analogy. Second is blown up balloon analogy. Third one is lily pad. And fourth one is the thumb opposing rule analogy. So first one in garden hose analogy. Speech mechanism is compared with water pipe hose. When pressure is applied, then water has permit to come out, then minimize the water through the hose or stop the water. When child aware through this technique, then therapy should teach about our speech production mechanism, how speech is generated and how pressure is applied, how pressure play a major role in glottis area. So as in diagram shown, how faucet is compared with the larynx or the voice box and nozzle is with lips and the garden hose with trachea. So it also describes when pressure is applied, then the water came out. It is same happened with the our speech mechanism. When pressure is applied with the lungs, then speech output is come out. So now second technique is the blown up balloon analogy. So in this technique, aerodynamic pressure is applied. Here, lungs are compared with balloon. So it is described if there is any kind of disruption, then airflow also affect. As same happened with our speech mechanism. If there is any kind of disruption or the constriction, then our speech output is also disrupted. Now see the diagram. How lungs and the balloon are compared with each other. Now third one is the lily pad or barrel bridge analogy. So in this analogy, frog movement is compared with speech mechanism. How frog jump one pad to another one by one. So it shows if there will be easy forward movement, then easy early speech output will be obtained. Therapist should tell the children that we should talk easily step by step, not in hurry. So if we can do this, then we can get speech output better. Now is thumb opposing rule. So in this, finger consider as a letter sound of short word and opposing thumb. There is 1 to 5 counting is used, like 1 for smooth, second is for easy, third one for forward switch, fourth is movement, and fifth is for forward movement repetition, and first and fifth both for the disrupted forward movement. That means a stoppage. Now, second technique is fluency initiating gestures, also known as fig. It includes 6 basic techniques like slow fig, easy fig, deep fig, smooth fig, loud fig, and last one is beat fig. These all fig are easy as their name indicates, so we can understand easily. So in slow fig, after reduction in rate of speech, it equalizes the prolongation of syllables. Then second is in easy fig, rate of speech is superimposed gently. In deep fig, controlled manner of inhalation to speech is used. In smooth fig, reduction in phonatory adjustment. In this, use of articulatory are light and appropriate. In loud fig, is a conscious and sustained increase or decrease vocal intensity. In beat fig, as name indicate, it includes rhyme, stress, intonation, prosody in controlled manner. Now, I will tell about therapy technique like mid-pass, delayed auditory feedback, and prolongation, and deep shallow breathing, which I told earlier. Now, mid-pass, the acronym for mid-pass is M for motivation, I for identification, desensitization, variation, approximation, and stabilization. Overall, in mid-pass, first clinician client rapport is building. After that, he will know about the cause his problem and fear. Then clinician tell about pseudo stuttering with giving examples so client can understand the difference of problem. Then client is taken out his or her fear. Then client is moved to approximation stage where he alter stuttering more acceptable form, where client learn all like cancellation, pull out, and preparatory sets are learned. So in last, stutter used to learn the skills to maintain speech in control manner. It is all about the mid-voice. So now I will tell about delayed auditory feedback. So it is one of most published therapy approach in which rate and prolongation control has been done. So delayed auditory feedback can be used in both children as well as in adults. So in deaf, articulatory disruptions like omission, interjections, repetitions are direct effect of deaf, and disruptions of pitch is indirect effect. So in deaf, there is analysis of rate of speech, easy onset, and flow of speech is basically used to evaluate disruptions. So in delayed auditory feedback, as name indicates, there is delay in auditory feedback and it is very useful to evaluate stuttering severity. So now I will tell about the cognitive behavior therapy. So cognitive behavior therapy play major role in psychological stuttering. It plays significant improvement in function and quality of life. So this technique includes fluency skills such as easy breathing, appropriate phrasing, and prolonged contingent punishment for the stuttering. So it involves effort to change behavioral patterns like it facing one's fear instead of avoiding them. Second is using role playing to prepare for potential problematic interactions with others, and last one is learning to calm mind and relax body. So its conclusion, it shows cognitive behavior therapy was partially effective in clients in regarding stuttering, reducing anxiety, reducing dysfunctional cognitions behaviors, and in improving quality of life. Now, most important thing are relapse in stuttering and counseling. Relapse is enemy of every therapy. So relapse is undesirable symptoms which comes after some time of release of therapy, which both under pressure. So there are so many reasons like false fluency, self-efficacy doubt, weak establishment, transfer of new speaking modes, dissatisfaction, client adjustment to new role, and failure to follow maintenance problem. So, in all conditions, continue effort is required. Now, part is counseling. In every session, clinician should counsel the client because after counseling, client will be motivated. If client will motivated, stimulus presentation of response will be increased or will be better. So clinicians should do behavioral counseling, humanistic counseling, existential counseling, cognitive counseling. So thank you all. I hope I am able to describe you all the things about management and therapy techniques regarding stuttering. Thank you.